Hello, my name is Nancy Richard. The topic is Candida endocarditis after TAVR. Definition is what is endocarditis? It is an inflammation of the inner lining of the heart chamber and valves endocardium. Infective endocarditis is caused by a bacterial or rarely fungal infection. Infective endocarditis on a prosthetic valve in account from the 10 and 30% and cause of all infection endocarditis develop most frequently after the 5th or 6th week after surgery, as long as it develops with the first 11 months after the intervention. It will be considered infective endocarditis relative to surgery early. Application in medicine. Causing agent Candida. Survival rate for patients with fungal endocarditis is 20%. Candida endocarditis is one of the most serious manifestations caused by Candida and is the most common cause of fungal endocarditis. When to suspect Candida endocarditis, persistently positive bowel cultures favors the base adequate treatment, new hair murmur, hair pharynx, embolid pneumonia. Pros and cons. The pros, the biology prostate present a much lower risk of thrombotic event and therefore can do without anticoagulation. The modern mechanical prostate quarantine ring longevity to structural failures. Patients might have valve replacement or those who cannot undergo valve replacement may be treatment with liposomal amphotericin B, amphotericin B deoxyxyl, fluoxetine, and fluconazole, and echinocandins. And cons, you may have complications like endophthalmitis and vertebral osteomyelitis, meningitis. In the infection spread, we will have the presence of phenix consistent with edema or infarctum, which may suggest the presence of emboli to the coronary circulation.
The pathogenesis of infective endocarditis begins with damaged heart valves from congenital heart disease, rheumatic fever, IV drug abuse, and the placement of intracardiac devices such as implantable defibrillators and pacemakers. Valve damage leads to sterile deposits of platelets, red blood cells, white blood cells, and fibrin called non-bacterial thrombotic endocarditis, or NBTE. If a sufficiently virulent organism is present in the bloodstream in sufficient amounts, it may colonize the damaged valve and its associated NBTE, and now the mass of bacteria and the NBTE becomes infective endocarditis. 80% of infective endocarditis is caused by gram-positive cocci, of which Staphylococcus aureus is the most common. The HASEC group of organisms consists of fastidious gram-negative bacteria that are an unusual cause of infective endocarditis. They are, together with fungal infections, notoriously associated with large friable vegetations, which can easily break off and cause emboli to vital organs. Enterococcus causes about 10% of infective endocarditis. Enterococcus is a notorious problem if it causes endocarditis because agents that interfere with the organism's cell wall can inhibit these organisms, but cannot kill them. However, bactericidal therapy is essential to prevent recurrence of endocarditis of any cause. Thus, for enterococcal endocarditis, potentially toxic aminoglycosides must be added to cell wall agents for the entire period of treatment to eradicate the infection. Diagnosis is confirmed by multiple positive blood cultures and visible vegetations noted on echocardiography. Definitive management of patients with infective endocarditis is best accomplished by an infectious disease specialist, and the nuances of antimicrobial therapy are beyond the scope of this lesson. However, while awaiting culture results, empirical therapy of native valve infective endocarditis with vancomycin plus ceftriaxone is recommended. For prosthetic valve endocarditis, the combination of vancomycin plus gentamicin plus oral rifampin is recommended because of the possibility of methicillin-resistant Staphylococcus aureus, or MRSA. This combination is also recommended for methicillin-resistant Staphylococcus epidermidis, MRSE. Adjustment of antibiotics can be made by an infectious disease specialist when available. In some cases of endocarditis, valve replacement early in the course of endocarditis should be considered because it is associated with a lower mortality than elective valve replacement after prolonged antimicrobial treatment. This includes patients who exhibit congestive heart failure, which is the most common cause of death from infective endocarditis. Patients with infection caused by organisms that are difficult to treat, such as enterococcus, especially on a prosthetic heart valve, as well as Staph aureus, aerobic gram-negative bacilli, and fungi are also candidates for urgent valve replacement. Previous cerebral embolism, or the presence of large vegetations which may embolize or compromise the heart's electrical conduction system, leading to heart block, are also indications for urgent replacement. The bottom line is this: if surgery is inevitable, early surgery has a better prognosis than delaying surgery. An endocarditis team consisting of a cardiologist, a cardiac surgeon, an infectious disease physician, a microbiologist, and an intensivist who discuss patients in the hospital with infective endocarditis weekly and make decisions about surgery has been shown to reduce mortality substantially. To complete the picture as an outpatient, follow-up by a cardiology and infectious disease specialist at 1, 3, 6, and 12 months after surgery is optimal.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to
Inside application in Ecuador, in relation to say is it said that it is more frequent in men with a 3 to 1 ratio due to the high prevalence of injected drug additionally in males. Regarding the incident and study conducted in Latin America between 2008 and 2010 that included 7 countries in the region, including Ecuador in the case and in the sense.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Endocarditis means inflammation of the inner layer of the heart. The heart's wall is made up of 3 layers, the epicardium being the outermost layer, then the myocardium, and then the endocardium, which is the layer that gets inflamed. It turns out that most cases of endocarditis are due to a microbial infection of the endocardium. Any area of the heart that's exposed to turbulent blood flow, like a narrowed cardiac valve or a septal defect, could be affected by endocarditis. Turbulence of blood flow causes damage to the endocardial lining. That damage exposes the underlying collagen and tissue factor, which causes platelets and fibrin to adhere, which forms this tiny thrombosis or blood clot. This is called non-bacterial thrombotic endocarditis, or NBTE, and it's non-bacterial because it happens even before the bacteria shows up. Then a microbe has to get into the bloodstream, and that might happen if a person has an obvious open wound or an abscess, a dental or surgical procedure, or injection with an infected needle or infected substance, usually while using illicit drugs. The valves are often affected because they're often the site of turbulent blood flow. Most often the valves on the left side are affected, the mitral valve and the aortic valve, sometimes due to predisposing conditions like mitral valve prolapse and bicuspid aortic valves. Risk factors for developing endocarditis include having prosthetic valves, having a congenital cardiac defect, having damage to the valves from rheumatic heart disease, and finally, intravenous drug use can put valves at risk.
In conclusion, an infective endocarditis is one of the cardiovascular infection with the highest morbidity and mortality. It is almost always fatal if it no treatment and in time. The valves are usually affected, but the infection can be located in a septal defect or in the mural endocardium. In Candida endocarditis, embolio in the great vessel and common. The embolio culture seems show the obtained from those prior to initiation of antibiotic therapy. Thank you.